behalf of Endocrine Society of India and Dr. Kaushik Pandit, President-elect of Endocrine Society of India and Chief Patron of this program, I welcome you all to March chapter of ESI case capsule. We have a renowned faculty today, Dr. Sanjay Saran from SMS Medical College, Jaipur, who have kindly consented to a faculty moderator for an interesting case of pheochromocytoma. Sir, please accept our sincere gratitude for accepting our invitation to be a moderator today. And we have a large panel of students who would be a panelist for today's case discussions. And in fact, whenever we have an overwhelming response, whenever we ask for the student volunteers to be a panelist, and this speaks how much impact this academic program have in endocrine training. And on behalf of Endocrine Society of India, I assure you that it is a constant endeavor to make this program better and better with each passing month. And I welcome Dr. Ranita Bhattacharya from Kolkata, Dr. Harini from Medical Institute, Bangalore, Dr. Hitashvi from Narayan Hrudalaya, Bangalore, Dr. M.N. Bhagyashri from KIMS Secunderabad, Dr. Isha Naik from SMS Jaipur, and I also a special thank to Dr. Himanshi, the SR from SMS Jaipur, who would be presenting the case on pheochromocytoma. And before we hand over to Dr. Saran, I would request Dr. Kaushik Pandit to just give a few words of motivation to all the students who are alive today with us for this case capsule. Sir, over to you.
Good evening. Thank you, Dr. Sandeep. It's indeed a great privilege to welcome all of you who have joined and would devote for the next 60 minutes to see a common case of pheochromocytoma and how diverse can it be. It's a very small step from the Endocrine Society of India to make the science of endocrinology progress in this country. We consider this as our onerous task as a guardian of the fraternity of endocrinologists in India, that the future endocrinologists become better and better and better. And for this step, Dr. Sandeep Kumar has taken this task of improving the case presentation, understanding, and the skills by introducing this case capsule. And I welcome all of you to enjoy, learn, and disseminate the knowledge amongst ourselves. Thank you very much.
Thank you, sir. Sir, Dr. Sanjay, over to you, sir.
Yeah, thank you, Sandeep, for your kind invitation, for giving me this opportunity on this platform, academic platform particularly. So thank you, Kaushik sir, for giving your valuable time to encourage us in this case program. So now, without delaying, we are just starting this case. So Dr. Himanshi Soni will present the case, and whatever the questions will be there will be taken over by all the panelists, all the students. So let's start with the case. Dr. Himanshi, you can start the case.
Yes, sir. Good evening, sir. Good evening, everyone. Sir, am I audible?
Yes, you're audible, and we are able to see your slides.
Good evening, everyone. So I'm presenting a case. A patient of 16 years, 7-month-old female presented to endocrinology department in December 2024 with complaint of weight loss for 1 year, paroxysm of headache, sweating and palpitation for 8 months, hypertension with postural giddiness for 8 months, and abdominal pain and constipation for 1 month. She was apparently well till 1 year back, when she observed gradual weight loss of over 16 kg over 1 year, and this was associated with decreased appetite. No history of fever, chronic cough, diarrhea, vomiting, steatorrhea, any drug history or intentional diet restriction. She started having complaint of episodic headache, which was insidious in onset, mild to moderate intensity, throbbing type, occipital, and sometimes holocranial, lasting for 10 to 15 minutes, associated with symptoms of associated with sweating and palpitation, not associated with vomiting, focal neurological deficit, seizure, or blurring of vision. Headache was relieved spontaneously with 3 to 4 episodes per week, mostly occurring at rest. And she has to drop her school due to fatigability and episodic headache for in May 24 only. And for headache, she consulted a doctor and was found to have elevated BP of 200 by 100 mmHg. And she was admitted for this reason in May 24, and her BP was controlled with some injectable. And she was later then initiated on some antihypertensive that she was taking thrice daily. Although headache initially resolved after initiating antihypertensive medication, she continued to have raised BP of systolic of around 140 to 150 mmHg and diastolic of 90 to 100 mm of Hg on home BP monitoring. But for last 1 month, she started having episodes of paroxysm of headache, palpitation, and sweating with frequency of 1 to 2 episodes per week. She started having complaint of headache, abdominal pain for 1 month that was dull aching, continuous in right flank region. There were no aggravating or relieving factor, and but that was associated with constipation, not associated with vomiting, menstrual bleed, dysuria, hematochezia, or any food intake. And one ultrasound was advised by a physician, which was suggestive of right adrenal mass.
So can we stop here once now? So can you go back on your first slide? Okay, so this 16-year-old female, okay. So she presented with weight loss. So was there any history of the long-standing disease before that?
No, sir.
No.
She
Okay.
gradually had weight loss, and she only had the decreased appetite.
Decreased appetite. Okay, then paroxysm.
And she started having complaint of fatigability along the duration of 1 year.
Okay, that is only for 8 months, paroxysm, and there's all hypertension.
Yes, sir.
Okay. Okay, next move.
Sir, shall I continue?
Yeah, so this 16 kg weight loss was over the 1 year of period only.
Yes, sir.
Okay. Okay, continue. Next.
On inquiry, there was no history of decreased urine output, hematuria, or periorbital pedal edema, no history of chest pain and dyspnea, no history of joint pain or skin rashes, no history of panic or anxiety attack, no history of weight gain, stria, easy bruisability, plethora, proximal muscle weakness or short stature, no history of darkening of skin over knuckles, mucosa, face, no history of muscle cramps, polyuria, weakness, no history of acne, hirsutism, clitoromegaly, deepening of voice, or menstrual irregularity. No history of snoring or daytime sleepiness or rectal enlargement. No history of tremors, weight loss. Weight loss was there and sweating was there. No history of tremors and neck swelling. There was no history of any other drug intake. No history of nephrolithiasis, bone pain or depression or confusion or any signs of hypercalcemia. No history of flushing or diarrhea. And no history of swaying, incoordination, intentional tremors, or nystagmus or gait abnormality suggestive of any cerebellar signs.
So, okay, can we go back to history on the first slide? So by this whole history, what could be the differential diagnosis in your mind?
Sir, patient is young and female, and she is having weight loss of significant weight loss over the period of 1 year, which is suggestive of a chronic illness. And she is having classical symptoms of headache, sweating, and palpitation. And there is a documented history of raised hypertension. And we have a documented ultrasonography suggestive of right adrenal mass. And she also had complaint of abdominal pain and constipation for 1 month. So probably etiology from adrenal only, causing hypertension and causing weight loss.
So what could be there?
Sir, it could be any of these classical symptoms are suggestive of catecholamine oversecretion. So any catecholamine secreting tumor or adrenocortical carcinoma or any young onset hypertension in females can be due to primary hyperaldosteronism, but such classical signs are usually absent in primary hyperaldosteronism.
Yeah, but actually, pheochromocytoma, what is the prevalence of pheochromocytoma?
Sir, prevalence is around 0.6 to 1%, around 2 to 8 cases per million population.
So it's very less, na?
Hmm.
So go to previous slide. Na? So here, the projection of headache, sweating, palpitation for 8 months is there. Hypertension is also there. So we can think of other things. What can be there? Other things like weight loss. A lot of causes are there for weight loss. But progenism of headache, sweating, palpitation. What are the DDs for this progenism? Differential diagnosis.
Sir, differential causes could be endocrinal, neurological, cardiovascular, or any other causes. Like in endocrine, we already have discussed this catecholamine secreting tumor, and other than that, there could be this could be due to thyrotoxicosis or due to events of hypoglycemia or any pancreatic neuroendocrine tumor causing hypoglycemia, or
Which pancreatic neuroendocrine tumor?
sir, insulinoma.
Okay.
Hmm.
Okay.
And
Other causes?
in cardiovascular causes, these symptoms can be due to angina or any arrhythmia, any right ventricular deconditioning, or but headache is usually not there in cardiac symptoms. Or there are neurological causes also, like migraine.
Headache can be there in cardiac symptoms. No?
Hmm.
Headache is usually there in many of the cardiac problems. No?
Okay.
So, any other cause?
Neurological causes like autonomic neuropathy or migraine or focal seizures, these presents with such things, or could be due to psychiatric illness like somatoform disorder or anxiety attacks, panic attacks, or hyperventilation, and like mast cell disease, mastocytosis, carcinoid syndrome.
Okay.
And in endocrinal hypogonadism is also there, which present as palpitation, hot flashes, sweating.
So these most are chronic diseases, or I think these are mostly these diseases are associated with the weight loss.
Hmm.
Okay. So now other thing in the patient is hypertension and the postural giddiness for 8 months. So what are the differential diagnosis of hypertension with postural giddiness?
Sir, autonomic neuropathy,
Yeah, that can.
Pheochromocytoma.
pheochromocytoma,
Yeah.
other. Sir, if patient is on any drug like sympathomimetic drugs or
Many other causes are there. You know, a lot of causes are there with hypertension, with postural giddiness. Endocrine causes.
Sir, even thyrotoxicosis can have hypertension with postural giddiness because of white pulse pressure.
Yeah, that can be there. Okay, let's move to other. There are other causes. Okay, abdominal pain and constipation for last 1 month. So, what can be there which causes abdominal pain and constipation in the patient of hypertension?
Sir, it could be due to mm, could be due to hyperparathyroidism, hypercalcemia present with hypertension and constipation, and abdominal pain also, apart from pheochromocytoma. Or
So, what is the cause of abdominal pain in pheochromocytoma?
So the catecholamines which are secreted, this is Harini. So the catecholamine oversecretion has an impact on the intestinal motility, and that could lead. Also, the abdominal pain could be because of the stretching of the adrenal tumor, or if there is any kind of necrosis or hemorrhage into the tumor, can lead to production of abdominal.
Yeah. Anything else?
Any
Actually, this is mainly epigastric pain is there. So in pheochromocytoma, we see the epigastric pain mainly. So what is the cause of this epigastric pain in pheochromocytoma? So we know abdominal pain is also, you can see the episodic is there. No? So anything is related to this?
The main 2A syndrome, hyperparathyroidism, hypercalcemia can cause epigastric pain.
But that is not the episodic. No? Hyperparathyroidism, hypercalcemia pain, I don't think it is episodic pain. No? So
Sir, this cholinergic surge causing vasoconstriction, and probably this can cause
yeah, this
ischemia,
is
mesenteric ischemia or something.
so mainly the thing is the hypertension. Okay. Then other thing is sudden rush of blood. Okay, that causes the epigastric pain. No? Okay, so then again, what the cause of constipation in pheochromocytoma?
So the catecholamine action on
increase sphincter contraction and reduces intestinal motility. So that will cause constipation.
And there is also hypokalemia associated with pheochromocytoma, adrenaline rush, and they can be pseudoparalytic ileus.
Okay.
Paralytic ileus.
Anything else?
Or they can be men 2A associated Hirschsprung disease, which could cause that, or abdominal intestinal wall neuromas associated with men 2B, which can cause obstruction and constipation.
Okay. Anything else? That is, I think that is more common. No? So you know the continuously high this catecholamines levels are there. So can they cause something?
receptor down regulation.
Yeah, that's a deconditioning. No? So that is more common. Okay, so come to next slide. Okay, so patient doesn't have any kind of fever, cough, diarrhea, vomiting, or these symptoms. Okay, so if you are considering the patient of pheochromocytoma, so how many, what's the frequency of spells?
In this patient or usually?
Usually.
Sir, this is variable. Matlab, if pheochromocytoma, if this is a familial cause or genetic cause, or if a cluster 1 mutation is there, then there is continuous release of noradrenaline and persistent hypertension, while in cluster 2 there is episodic release, and these frequency is variable.
Okay, so what is the duration of spells?
15 to 20 minutes usually.
Okay. So which is the most common feature of spell?
Headaches are in 60 to 70% cases. Headache usually is the first presentation.
Okay, okay. So go to next slide. Okay, so patient was on ultrasound, he was found to right adrenal mass.
Yes, sir.
So how will you proceed to evaluate the right adrenal mass?
Sir, investigation wise?
Yes, you just got the right adrenal mass in some patient who is in hypertension, then constipation is there, abdominal pain is there. So how will you evaluate that patient?
Sir, if probably the cause of hypertension is in the adrenal only. The source is adrenal only. So we will rule out the common causes. We will go for first we will go for these biochemistry, electrolytes, ABG, and CBC, and then for hormonal workup we will proceed with this 8 AM cortisol, ONDST, then plasma renin concentration, aldosterone, and then we'll advise uh, plasma-free metanephrine or metanephrine, preferably by LCMS if available.
So okay, so right adrenal mass was what could be there? What could be the biochemically? What could be there? So you will go systematically, no? It's not like that. You will just examine all the tests, no? Systematically go. So how will you go systematically in this patient of right adrenal mass with hypertension and other features?
So here, young onset hypertension with features classically suggestive of spells and USG suggestive of adrenal mass. I would first like to look at the characteristic of the mass. This does make us think of a high probability of Pheochromocytoma, but though it would be better to look at the characteristic of the mass on a CT contrast enhanced CT abdomen as well.
Yeah,
and on the other hand, we will also proceed with biochemical investigation.
Tasvi, just listen. Actually, we have not done the CT. Okay, we have done only ultrasound, no?
So we must first proceed with biochemical investigations, and if there is a strong index of suspicion, if it is elevated more than 3 times the upper normal limit, we could proceed with radiological investigation.
Okay. So what are the precautions we will take before just going for these categories?
So pertaining to plasma-free metanephrines and norepinephrines, there are certain drugs which could interfere with their value. For example, tricyclic antidepressants, paracetamol, decongestants, or glucocorticoids. So these medications, it's ideal to stop it at least about 2 weeks before taking the sampling. And the sample is ideally, preferably taken in the supine position and drawn after being recumbent. Because in the standing position, there can be excessive sympathetic adrenal activity, which could lead to false positive results.
Sir, patient is advised to rest for 20 minutes. And if patient is of young age, then it is advised to precannulate that patient and or take the sample in one prick only.
Okay. So what kind of sample you will take? You will take the plasma. Which one? Which you will take sample to rule out the pheochromocytoma in this patient?
We can take plasma-free metanephrine or metanephrine or urinary 24-hour catecholamines.
So which is better?
Sir, plasma.
Plasma.
Plasma-free metanephrine or metanephrine.
So sensitivity is high.
Sir,
free metanephrine or 24-hour urinary metanephrine's?
Sensitivity is more for plasma.
Sir, sensitivity
almost reaches up to 100%.
But sir, sensitivity is almost
there is
same.
Sensitivity and specificity are 98%, sir, for urinary 24-hour or metanephrines. But when the suspicion is high, then we can go ahead with the plasma metanephrines itself, because the false positive rates are high with the plasma-free metanephrines.
So it's always better to go for 24 urinary this metanephrines. So that is better. The sensitivity and specificity both are better than plasma free metanephrines. Okay, so for the urinary free metanephrines, what are the precautions you will take?
So we should measure creatinine for proper collection.
Okay.
To measure the proper collection and
how will you advise to collect the 24-hour urine?
So, sir, the can has to be the can that they will be collecting in urine need to have a preservative. Usually they use acetic acid as a preservative, and that has to be kept at room temperature till collection. So after voiding first morning sample, they have to collect next day morning, and after collection they have to, the same day they have to transport it to the laboratory. If they cannot, then they have to freeze it.
Okay.
But sir, there is high variability in urine collection, so it is better to advise and go for plasma-free metanephrine and normetanephrine, I think.
But why high variability is there?
It is, if patient is in IPD and if we are monitoring the urine collection, then it is okay. But on OPD basis, it is totally on patient. We have to rely on how
You usually
he or
have
she
to
is.
advise them, if they are working, they have to collect this sample when they are at home voltage.
But in many
Yes.
cases, in other diseases also we are advising this 24-hour urinary collection. So I don't think the problematic is, it's not the problematic. So it may be problematic in particularly children's, but not in elderly ones. No? And the patient is 16-year-old, so she is adult enough. So what are the other tests you can perform if they suppose she refuse to take the 24-hour urinary samples? Then what will you do?
So then we will go for plasma.
Okay, so plasma catecholamines or metanephrines you do?
So metanephrines.
Metanephrine or metanephrine is
Metanephrines, normetanephrines.
So what is this metanephrines and normetanephrine? Why we are doing? Why not this epinephrine or norepinephrine?
Sir, metanephrine and normetanephrine are more stable to perform.
Okay.
And
what is fractionated this metanephrine? Why we are saying fractionated?
Sir, fractionated term is used for urinary metanephrines. If we use total metanephrine word in urine, then it means both metanephrine and both metanephrine and normetanephrine. And fractionated means we are doing separately free metanephrines and normetanephrines in urine. And free terms is used when deconjugated metanephrine and normetanephrines are not measured.
Okay, so you have
conjugated.
You have checked out. So now suppose the things are fine. Now metanephrine and normetanephrine are not raised. So what is the limit of this metanephrine to diagnose the pheochromocytoma?
More than 3 times the upper normal limit.
Okay, for normetanephrine?
Sir, more than 2 times upper limit of normal in plasma and more than 3 times in urine is, I mean, it is suggestive of catecholamine secreting tumor.
Okay, so is there any problem? Suppose patient is having renal failure, then what will you do?
So then we will go for catecholamines. Usually, there is normally 3 times catecholamine are raised in CKD patients. So we will take this range, more than 3 times of upper normal limit of catecholamines.
Okay. Now suppose the catecholamines levels are normal and this metanephrines are normal in this patient, then what will you do?
But sir, clinically there is high suspicion of pheochromocytoma, and if biochemically metanephrine and normetanephrine are does not favor, then we will go for imaging.
Okay. So will you not do these tests during spells?
Yes, we can repeat.
Advisable to do the test during the
spell.
Okay. So anything else, suppose then again the things turn out to be normal, then what will you do?
We can repeat the test after 2 to 3 months.
Okay. So what are the other tests to be done in patients of this adrenal incidentilloma? Because in the patient, the hypertension is there, abdominal pain is there, and the spells are there. So that can be there in other diseases also. So it's not that pheochromocytoma is only the diagnosis here.
Sir, we will look for cortisol. We will do overnight dexamethasone suppression test. We will look for Diaz level, 17 OHP levels, androstenedione levels for adrenal mass.
How will you do this ONDS test?
Sir, we give 1 milligram of dexamethasone one night before the sampling at 11 p.m. and then next morning at 8 a.m. we advised serum cortisol level.
So in all the patient 1 milligram, or is there something dose?
No, sir, it is age weight dependent. In infants, it is weight dependent. 15 milligram per kg body weight for 15 milligram per kg meter square for ONDST in children less than 10 kg, I think.
Less than 40 kg children,
Less
the
than
dose
40
is
kg.
ONDST dose is 15 microgram per kg dose. And if we are doing LDTST, then it increases to 30 microgram per
30.
kg.
Okay. Now suppose that is normal in this patient. ONDST is normal. Then what test? What else you will do?
We will also do test for primary aldosteronism. Since there is an incidentalloma, we have to rule out functional hormonal hypersecretion. So we will be advising, we will be looking at the serum potassium first. If serum potassium is normal and patient is not on antihypertensives like ARBs, AC inhibitors, then we will be going ahead with the plasma aldosterone concentration and plasma renin activity ratio or direct renin concentration with ratio.
Okay. So we will do PEC-PRA ratio. So what should be the result of this PEC-PRA ratio?
So ratio more than 20 is
suggestive of primary hypertension.
Okay. So what is the unit of plasma aldosterone concentration in plasma renin activity?
So it has to be more than 10.
Pardon?
It has to be more than 10 with suppressed plasma renin activity.
Okay. So what is the unit?
Sir, for concentration nanogram per deciliter and for urinary nanogram per deciliter per hour.
Per hour. And per ml per hour.
Per ml per hour.
Yeah, ml per hour is not deciliter per hour. So okay. So now this test is also turns out to be normal. Then what will you do in this patient? So now the patient is having hypertension, spells are also there, and then epinephrine and this metanephrines are normal in this patient. Okay, so now what will you do in this patient? And ultrasound is showing right adrenal mass.
Would you proceed with imaging for localizing the tumor, sir, or we could go ahead for a functional imaging to understand if there's a secretory component?
Yeah,
So there could be other paraganglioma which could be secreting. So we should go for a like MRI or functional
But
study.
sir, these metanephrine or metanephrine tests have extremely high sensitivity, so almost reaching up to 100%. So in case they are repeatedly normal, that does rule out catecholamine secreting tumors. That is, I think that is one of the reasons they are given as a screening test.
but strong suspicion is there. Then what will you do in this patient?
Sir,
In that case, sir, we can.
As you don't see any other cause, then what will you do?
You can repeat the test in 2 to 3 months.
Yeah, you can repeat. No? Then other thing is that if strong suspicion is there in this patient, then you go directly for the imaging study.
Imaging.
So what kind of imaging study you do in this patient?
You can do thing for localizing it, so you could use CT or MRI, or for functional imaging, we could use gallium dotate or
Dotatate.
Dotatate PET.
Okay. So you have done the CT scan. Which will you prefer, CT scan or MRI in this patient?
the CT scan.
Sir, thorax and abdomen, pelvis, we will do the CT scan. For head and neck, it is better.
For
We
MRI.
have better resolution.
Okay. So why not MRI in thorax and abdominal or pelvis?
Sir, we can go with MRI as well, but the spatial resolution is better with CT. Though the paragangliomas and pheochromocytomas have good, they are quite reproducible on MRIs as well. As we see, T2 hyperintensity is quite very specific for paragangliomas and pheochromocytomas.
Okay, but MRI will not show this. What is the sensitivity of CT and MRI in this regarding this paraganglioma?
MRI has a sensitivity of about 95% and
95%.
specificity of about 70%.
70 is
See,
very, I think.
95.
Almost 85%, 85%, 85% CT sensitive, sir.
Yeah. So it's almost same, just MRI in little bit higher sensitivity regarding this tumor. So we can go CT. CT is preferably we'll go for CT because it's very easy to do and you'll get the result very fast. Okay. So after doing the CT scan, suppose you are getting some this right adrenal mass is there. Okay. So how will you say it is pheochromocytoma? What are the symptoms of pheochromocytoma? Sorry, what are the features of pheochromocytoma in the CT scan?
Sir,
Heterogeneous, sir, with more than 10 HU.
so size more than 3 centimeter. Then there is a heterogeneity. There could be areas of hemorrhage or calcification or cystic changes. Then baseline tone contrast enhancement is more than 10 HU, suggestive of pheochromocytoma. Then in arterial phase, enhancement could go high up to 130 HU also. And then if we have delayed enhancement value of that in that CT, then we can calculate washouts. And this pheochromocytoma usually have delayed washouts. Usually. But
Anything else which have delayed washout? Any adrenal, other adrenal tumor?
sir, adrenal cortical
Adrenocortical carcinoma.
carcinomas, metastasis, these all have delayed washouts.
So how will you differentiate between the this carcinoma?
The pheochromocytoma will be heterogeneous, but it could be quite cystic, whereas ACC could be heterogeneous, but there could be mixed densities on.
Solid with
And
cystic.
usually margins is irregular in ACC.
Irregular.
Metastasis.
Irregular. If you will be smooth margins.
Usually are bilateral.
Okay, so you have done this CT scan and you are just getting it suggests you pheochromocytoma. So what else you will do right now after doing this CT scan?
Sir, we will go for screening to look for any paraganglioma or if present in that patient. So for that we will go for MRI brain and base of skull, then MRI spine, CT chest and thorax. These are common sites for paragangliomas.
Okay. So what are various?
Since this is pheochromocytoma in a young patient less than 20 years old, so there are high chances of this being a familial pheochromocytoma. So we will also look for the other sites of metastasis as well, as they can be quite aggressive in nature.
So okay. Now move to the next slide. So why you ask the decreased urine output, hematuria, and periorbital pededema, these things?
Sir, to rule out renal causes, renal parenchymal diseases and renovascular hypertension is also common. Secondary cause of hypertension.
Okay. So in the patients of this pheochromocytoma, is there any chances of having some acromegaly or type that you ask the patients regarding?
Sir, if there is ectopic GHRH secretion associated with pheochromocytoma, then signs of acromegaly can be there.
Okay. Okay, next slide. Next slide. Okay, now let's move to this development history.
Antenatal history, she is firstborn child of non-consequence marriage, no maternal hypertension and GDM. She was delivered full term by cesarean section in view of non-progression of labor, and birth weight was 3.4 kg with no atypical genitalia. And developmental history was also normal, and she studied till 9th standard and dropped from school in May 24 due to illness. Puberty, Minak achieved at 12 years of age. Cycles were regular and lasting for 3 days per month. And sleep is disturbed due to headache. Appetite is decreased and bowel habits, constipation as described before. There was no significant family history. There was no history of young onset hypertension, any cerebrovascular or CAD event, or any such similar episodes of paroxysm or hypothalamic paresis in any family member. No history suggestive of any thyroid or renal or cardiac illness, and no history of recurrent nephrolithiasis or fracture. And treatment history during admission for hypertension in May 24, the patient was started on some antihypertensive. She was taking that antihypertensive thrice daily.
Okay. So, yes. Okay, let's move on, summarize the case.
So 16-year, 7-month-old female presented with complaint of unintentional weight loss for 1 year with paroxysm of headache, palpitation and sweating for 8 months, pain, abdomen and constipation for 1 month. And she is hypertensive with blood pressure poorly controlled on one antihypertensive drug, which she was taking thrice daily, and one ultrasound was suggestive of right adrenal mass.
Okay, next.
Her vitals, pulse was 34 per minute, normal rhythm, normal vessel wall, no radioradial or radiofemoral delay. All peripheral pulses were palpable. BP in all limb was 150 by 100 mmHg, which was more than 95th centile for her age. And there was significant postural drop. Supine BP was 150 by 100 with pulse rate 94, and standing BP was 130 by 90 with pulse rate of 102. And on general physical examination, there was significant pallor present, and height and weight were almost normal, but BMI was 16.8 kg per square meter.
Okay, so the orthostasis, what are the various reason of orthostasis in case of pheochromocytoma?
Sir, due to severe vasoconstriction, there is state of dehydration present in pheochromocytoma due to intravascular fluid volume depletion, and there are this baroreceptors insensitivity is also there in these patients.
Any other cause? So other students can also take the questions. There are a lot of other causes of this orthostasis in case of pheochromocytoma.
The intravascular volume depletion would be one of the major reasons why. Desensitization of the vessels because of the catecholamines when there is intravascular volume depletion, because of the episodic nature of the catecholamine release. These are some of the reasons why orthostatic hypotension could happen in pheochromocytoma.
Other causes?
Sir, a drug started, sir, prazosin will also cause orthostatic hypotension. Started, and other is epinephrine secreting, predominantly epinephrine secreting will classically have orthostatic hypotension because of intense vasoconstriction.
And they are more sensitive to beta-2 receptor than alpha-1 receptor, so they will cause vasodilation and
vasodilation as well.
Okay, are there any secretion is there substance which causes orthostasis? Like epinephrine. Okay.
So some adrenomedullin,
move to
dopamine secreting tumors.
Okay, show previous slides. Previous one. So how the family history relevant in this patient?
Sir, there are some mutations with high penetrance percentage. Around 30 to 50% penetrance is there in some mutations related to some SDH and cluster B syndromes like MEN2. They all will have, they can have a significant family history, such similar episodes in one or other family members.
So how many of the Pheos are familial?
40%.
40% are heritable, sir.
So 40% is too big number, no? So we
no, sir. Only 40% of paragangliomas are heritable. Pheo only 10% are familial. That is adrenal pheo 10% are familial. But if paraganglioma is there, that percentage increases to 40%.
Okay. So what are the various familial syndromes associated with pheochromocytoma?
So MEN 2A, 2B, then there is von Hippel-Landau's disease, and there could be familial paraganglionoma syndrome 1, 2, 3, 4. Then we have SDH mutations like SDH B, C, T.
So then familial polycythemia, neurofibromatosis 1.
So how many patients of neurofibromatosis are having pheochromocytoma?
Sir,
3%.
this is very rare, 3%, around
3%.
3%.
Okay. So in MEN 2A, which is more common, MEN 2A or MEN 2B?
Both are 50%.
More
MEN
common.
2A is common.
Okay.
And 50% pheochromocytoma is 50% in these MEN 2A and MEN 2B.
MEN 2B as well.
The differentiating feature will be that primary hyperparathyroidism will be seen in MEN 2A than MEN 2B, and medullary thyroid CA, which is associated with MEN 2B, has a far more aggressive course than MEN 2A. The presence of
Found in all
mucosal
100%
neuromas, marfanoid habitus, and intestinal ganglion neuromas are seen far more in MEN 2B than MEN 2A.
So MEN 2A, which gene is affected?
Sir,
The
red proto-oncogene activity.
Can you explain this full form of this gene?
Full form.
Full form.
Full form.
Okay. So which hormone, whether it is adrenaline or noradrenaline, which is secreted more in pheo with MEN 2A?
So it's epinephrine, which is more predominant in MEN 2
Okay.
because of the overexpression of PNMT.
So synthesis of epinephrine is in the chromaffin cells. So where it is synthesized, epinephrine?
Sir, inside the chromaffin cells, it is synthesized from non-epinephrine is get converted to epinephrine. So non-epinephrine is present in vesicle that gets leaked, and then in cytoplasm, PNMT enzyme is there which converts non-epinephrine to epinephrine, and that is further stored and reuptake by VMAT transporter and stored in vesicles. So
okay. So in case of MEN 2B, which is predominantly secreted, whether norepinephrine or epinephrine?
epinephrine due to increased activity of thyroxine hydroxylase and PNMT enzyme.
So these are the familial pheochromocytoma paraganglioma are very commonly seen. Okay. So how will you genetically counsel the families?
Sir, pheochromocytoma is a curable condition, and it is a very lethal condition. So it is better to screen all family members to look and to have early diagnosis and treatment.
Okay. In which kind of the patients? Tell me the patient profile where the genetic counseling is necessary.
So patients who have bilateral pheochromocytoma, one who has a family history of the genetic syndrome or having having an adrenal mass along with other syndromic presentation,
Bilateral,
like cerebral hemangiomatosis and younger age at onset, less
And
than
history of
24.
paraganglioma and metastatic disease also.
Okay, in this patient, this kind of patients, you need to have this genetic test, and for the genetic counseling, you will counsel the family regarding this kind of the patients. Okay. So, what are the other just mutations which causes this paraganglioma?
VHL related pheochromocytoma.
What are other features of VHI?
Cerebral hemangiomas, retinal hemangiomas, and clear cell RCCs.
RCC
Other could be
pancreatic neuroendocrine tumors, endolymphatic sac tumors of the ear, broad ligament and epididymal
cystadenomas,
cyst,
papillary
cystadenomas.
cystadenoma,
And RCC can also be renal cell carcinoma, clear cell type, sir.
and pancreatic serous cystadenoma.
Okay, so now that suppose a patient is having this pheochromocytoma, you are diagnosed on the basis of this, and you have done this all the CT and MRI of the skull base and these all things, but it turns out to be negative. There's only one pheo and one adrenal gland is there. Okay, so now how will you proceed the patient? How will you alert the patient?
So,
we will
so
go-
then a choice of treatment becomes surgical resection. So we will be preparing her for surgery. So pre-op preparation, we will start with alpha blockade followed by a beta blockade.
Okay, so in such kind of patient where only one-sided pheo is there at the age of 16 years, is the genetic counseling or the genetic testing is important or not?
Yes, so it is
Yes,
important
sir.
because unilateral pheochromocytoma in a young age, it's probably seen in VHL. VHL is one of the conditions where unilateral pheochromocytoma presents at a younger age.
Okay, now move to the next slide.
Physical examination, SMR is normal, bilateral, A plus, B5 and B4. Three swellings of approximately 2 to 2.5 centimeter, firm in consistency, non-tender, non-motile, palpable on parieto-occipital areas of scalp. No hyperpigmentation, hirsutism or clitoromegaly, no stria, bruises or plethora or proximal muscle weakness, no tremors, no acral enlargement, no acanthosis or nigricans or skin tags, and there were no neurocutaneous markers such as cafe spots, axillary or inguinal freckling, scoliosis, bony lesions, amyloid lichen amyloidosis, marfanoid habitus, or bony lesions. Then system-wise examination, per abdomen was soft, no abdominal mass was palpable, and no flank bruit. Apex was heard at fifth intercostal space, medial to mid-clavicular line, no thrills, S1, S2 normal, no murmur. Respiratory systems was normal, CNS was normal, but on fundus, grade 2 hypertensive retinopathy was present, but there was no papilloedema or retinal angioma. So on after examination, after summarizing the case, 16 year 7-month-old female presented with weight loss for 1 year, paroxysm of headache, palpitation, sweating for 8 months, abdominal pain and constipation for 1 month, and was found to have hypertension with baseline BP of 200 by 100 mmHg with evidence of right adrenal mass. And on examination, BP was elevated, was more than 95th centile, with orthostatic hypotension and fundus showing bilateral grade 2 hypertensive retinopathy with no feature suggestive of any syndrome.
Okay, next.
So possible differential diagnosis could be first is catecholamine secreting tumor, possibly pheochromocytoma or adenocortical carcinoma, but there were no Cushingoid features, no signs of hyperandrogenism. There is possibility of aldosterone producing adenoma, but but the presence of these classical symptoms and absence of any signs of hypokalemia and polyuria are not favoring aldosterone producing adenoma. It rarely could be due to a Cushing syndrome or congenital adrenal hyperplasia, but these are very rare possibilities.
Okay, next.
So on investigations, hemoglobin was low, 8.6, but potassium, calcium, and electrolytes were normal. And hormonal workup, ONDST was normal, 0.9 microgram per deciliter. Aldosterone, renin was normal, but plasma-free normetanephrine, which was done by LCMS method, was 2,880 nanogram per liter.
Okay, next.
USG, which was already done by some other doctor, was suggestive of 45 into 34 into 55 millimeter right suprarenal mass, probably pheochromocytoma. Renal artery Doppler was normal. ECG was suggestive of signs of LVH, and echo showed ejection fraction of 65% with grade 2 diastolic dysfunction and concentric LVH. So this is a CT scan, which CCT abdomen, which showed ill-defined heterogeneous mass of 53 into 39 into 73 millimeter with pre-contrast enhancement of 35 HU, arterial enhancement of 98.7 and venous phase enhancement of 81.59 in retroperitoneal location along IVC encasing right renal artery and the suprarenal mass extension with non-separate visualization of right adrenal mass. So there were possibility of paraganglioma or right adrenal pheochromocytoma.
Okay, next.
After doing screening, CT thorax was suggestive of heterogeneous mass lesion in posterior ribs of left, fourth, and fifth rib. This could be neurofibroma or secondaries, but MRI neck and base of skull was normal. MRI brain with contrast showed multiple nodular signal intensity seen in skull vault in diploid space and parietal scalp on both sides, suggestive of secondaries.
Okay.
So we advised functional scanning. 18F Notanok PET CT was done, and Notanok avid soft tissue mass involving right adrenal gland with lytic lesions in left parietal bone of skull, bilateral occipital, left frontal, left fourth rib, multiple cervico-dorsal lumbar vertebrae, bilateral iliac blade, sacrum, bilateral acetabulum, and right proximal femur shaft.
Okay. So, when these functional studies are indicated in patient of this adrenal mass?
Sorry.
When the size of tumor is more than 5 centimeter, and if there is any evidence of metastasis or paraganglioma, we go for functional scanning.
Okay. So, is there some other name of this F Notanok?
Other name. So we usually go for gallium-68 DOTA TET PET, but
So same thing is there, no? Okay. So, okay, next, move to next. Now. We are running short of time.
Sir, diagnosis probably norepinephrine secreting right adrenal metastatic pheochromocytoma with multiple bony metastasis. For management, patient got admitted. She was previously on minifidipine 20 milligram TDS, which was gradually tapered and shifted to prazosin 2.5 milligram BD, and which was escalated to 10 milligram BD with monitoring of BP and heart rate in supine and standing position. And after 3 days, when symptoms of nasal congestion and orthostatic hypertension and increased tachycardia appeared, that is BP of 140/90 mmHg with pulse rate of 98 in supine with BP of 130/80 with pulse rate of 110 in standing position. Then we added metoprolol 25 milligram BD, and we increased up to 50 milligram BD, and target heart rate was achieved of 60 to 80 beats per minute. But her BP was controlled, that is 120/80 mmHg with tablet nifedipine 20 milligram BD, prazosin 10 milligram BD, and metoprolol 50 milligram BD. But throughout this course, she was advised high salt intake of around 15 gram and high fluid intake, and 2 to 3 liter of IV fluid was given daily. Patient was sent to urology for debulking surgery, but they found tumor inoperable due to close proximity to IVC. So they sent tissue for histopathology, which showed large nest of cords of epithelioid cells separated by stroma, cells showing ovoid polygonal nuclei and granular cytoplasm, and atypical mitosis was there of about 6 per 10 HPF, and focal areas of hemorrhage and necrosis was noted, and Ki67 activity was 4.2%, and chromogranin A and synaptophysin was positive. So this histopathology was highly suggestive of high risk of malignancy. Patient was then referred to medical oncology department. So they started patient on cyclophosphamide 70 milligram per meter square on day 1, vincristine 1.5 milligram per meter square on day 1, and dacarbazine to 600 milligram per meter square on day 1 and day 2. And this cycle is to be repeated every 21 days. And patient was checked for CBC, ECG, LFT, RFT, and checked for signs of sign and symptoms of peripheral neuropathy every time before chemotherapy. So till date, she has undergone 2 cycles, and we planned a genetic study and anti-resorptive therapy for metastatic bone lesions and family screening, which is yet not done.
So, okay. So before this pre-operative preparation, how will you do the pre-operative preparation in this patient? As you are given this prazosin and metoprolol. So you will start directly with metoprolol or something depending on the patient's condition. You will change your decision. Suppose the patient is having some cardiomyopathy is there or blood pressure is very low in the patient. So at this time, what you will do? But patient is already in heart failure. Then what you will do?
Sir, this time also, sir, alpha blockage should be given followed by beta blockage, but fluid intake is monitored with BP and heart rate and pedal edema. and it takes longer to control this for pre-op preparation in patient of recent MI and cardiomyopathy.
So anything else you can do, because the blood pressure is always very low. So how will you give this alpha blocker or beta blockers? How will you start this?
Volume resuscitation should be done here.
Okay.
Patient.
So volume resuscitation, how will you do in the patient of which is in heart failure?
So we can give vasopressors.
Vasopressors.
So they require pulmonary capillary wedge pressure monitoring. So these are given in ICU setting only.
So very judiciously you will replace the fluid in such kind of the patients. So other thing, after blocking alpha beta blockage, you cannot give in such kind of the patient who are already in failure. So what will you do in these patients? Do we have some other medications for such
So we can give metyrosine.
Tyrosine.
Metyrosine is mainly
phenoxybenzamine.
The calcium channel blocker we can use.
Yeah, we can use calcium channel blockers. No? So in such kind of patient, we can use calcium channel blockers. Calcium channel blockers will not decrease, will not cause a fall in the blood pressure in such kind of the patient. So we can prepare very well patient with calcium channel blocker. So this turns out to be malignant pheochromocytoma. So what is the prognosis in malignant pheochromocytoma?
So prognosis is poor.
Poor is a single line. How many percentage are there? So can you just explain?
Sir,
What is survival?
10 to 17% of the pheochromocytomas could be having metastatic.
5-year survival is around 14 to 20%.
No, it's not there. I think you just changed something. Though prognosis is very poor in case of malignant pheochromocytoma, but it depends on the progression of disease.
Yeah.
So, can you do surgery in case of malignant pheochromocytoma, or just you will just take the tissue and for the biopsy and you
No, sir. If surgery is advisable. If a surgeon can do surgery, debulking surgery is necessary. Though this disease is metastasized to bone, but to decrease disease burden, debulking surgery is advisable.
Okay. What are the other medicines, as you had given the cyclophosphamide, vincristine, and dicarbazine in this patient? So, any other medications which can be used?
Temozolomide.
Temozolomide, capecitabine, then this
Sunitinib
and
Sunitinib has recently shown quite good results in malignant pheochromocytomas.
Sunitinib and cabozantinib, and then there are PD-1 inhibitor, pembrolizumab. There are PARP inhibitors, olaparib and niverep, something olaparib, and then PRRT therapy can be given, but these are usually given in low activity cases like MIBG 1 iodine 131 MIBG or 177 lutetium and 90 yttrium PRRT therapies are also available.
Okay, thank you. It was great discussion regarding this case. Okay, thank you, Himanshi. You just prepared the case very well. Thank you very much. Thank you to all the students.
Thank you, sir.
Thank you, sir.
So now over to Sandeep.
Thank you, sir. And it was truly a very, very insightful discussion of pheochromocytoma. And I'm sure we are now, it will be very easy for all of you to, attempt the quiz session. So now we progress to one of the most awaited event of the part of this ESI case capsule is a quiz. And so basically, so I hope you can stop me if my slides are not visible to you. So I'm presenting the quiz on the Menti platform. So all of you would be knowing the quiz, we do it on a menti.com. And the way to access this quiz is simply scan the QR code or go to the menti.com on the website and enter this code number, which would be displayed in all the slides. So before we proceed further, let's clarify the rules of the quiz. So just scan the QR code or enter the code. And it's important that if you somehow log out during the quiz session, you can again enter simply by entering the code which is displayed on the top of this slide. And all the slides of this quiz would be displaying this code, which is ending by 111. And it's very important that you need to have two smart screen devices. One which you are seeing right now would simply be used to seeing the questions. And you need to have another smart screen device like your phone from which you can attempt the questions. And we are not looking for the correct answers, but it is the fastest correct answer. So you may lose even if by making all the answers correct. And we don't have any negative markings for this quiz. And not to mention that decision of the quiz master would be final. So we give some time for all the participants to join, and slowly the number who have joined is increasing. And so we give around 10 to 15 seconds more for everyone to join and get accustomed to this, the two smart screens, and we will begin with the quiz then.
Sir, can you reshare the QR code?
Okay. Okay. So this is a QR code. So there are two ways to access this quiz. Simply scan this QR code from smart screen devices, or you can go to menti.com website and enter this code which is displayed, and this code will directly lead you to the quiz. Okay. I think we are good to go, and the most of the participants have joined by now. And so get ready, please get hold of your the answering device, and I will be displaying the question number 1 of today's quiz. So here comes the question number 1. It says the Roizen criteria is used for assessing the pre-operative preparedness of pheochromocytoma. Which of the following is not a component of this criteria? No blood pressure more than 160 by 90, 24 hours before surgery. Blood pressure when the patient is standing should not be less than 80 by 45. No STT changes in ECG for at least 1 week. No more than 5 PVCs per minute in the ECG, or none of the above. So which one is the correct answers? Well, which one of is not the component of this criteria? So the correct answer for this is none of the above. So all the 4 criteria are the part of this Roizen criteria. It is a very interesting criteria. It's help us you in deciding which patient is fit to be taken up for the operative management of pheochromocytoma. So all the 4 components are part of the Roizen criteria. So answer for this question was none of the above, and 12 of you could answer this well. So let's proceed to seeing the leaderboard, and we have at this junction, we have Dr. Sachin, Dr. Anuj, Dr. Archana. These are leading the quiz, but no problem. This was the first question. We have a lot of scope to improve, and all the best. So I want to mention, we are looking for the fastest correct answer. So now we proceed to question number 2. And here the question number is there on your smart screen device. So based on screening studies of secondary causes of hypertension in outpatient, the prevalence of pheochromocytoma has been estimated to be how many % out of this? And this is very simple and has been discussed in today's case discussions as well. So which one is the correct answer? So correct answer is 0.1 to 0.6%, and 27 of you could answer it correctly, and sadly, many of you could not make this correct. So I'm just want to highlight it here that all these questions are coming directly from your Williams latest edition. So please, very important to go through your Williams in detail, and most of your question would be from your Williams. So the 0.1 to 0.6% is the correct answer. And we now proceed to next question. So question number 3 is here on your screens. So typical duration of pheochromocytoma spell, which was there in our patient also, is 15 to 20 minutes. So it is also associated with increased sense of body heat and sweating, which are common symptoms. But these symptoms happen in which phase of this pheochromocytoma spell? Towards the end of the spell, towards the beginning of the spell, or towards the middle of the spell? So you have to choose the one correct answer out of these 3 scenarios. So all of you have answered now, and the correct answer is towards the end of the spell. So classical Pheochromo spell, and this again comes from your Williams 15th edition, is described to be a 15 to 20 minutes, and patient can have many spells in a day. But the sweating and the sense of heat is present towards the end of these spell. So question number, now we proceed to the next. So we have a letterboard check, and so let's see how our participants are doing. And so now we have a reversal here, and we have a Dr. H who has not identified himself or herself, and he's leading with, or he or she is leading with 2,600 points. But we have a close fight between Dr. Archana, Priya, Aditya, Anuj, and all the best to you, because we have not even through 70% of, not even through 30% of today's quiz. So we proceed to the next question, and the next question is here on your screen. So for case detection strategy in pheochromocytoma, plasma fractionated metanephrine should be chosen in all except, and this was discussed during the case presentation as well. So it should be chosen in which of the, it should be chosen in out of these all the option, which is a condition in which it should not be chosen. So the options are high clinical suspicion cases, children, dopamine hypersecretion, or none of the above. So the correct answer was none of the above. Sadly, most of you could not answer it. So the plasma fractionated metanephrine is basically the test of a choice in whenever you have a high clinical suspicion cases, because it gives a higher number of false positive cases. In children, it becomes an obvious choice because it is very, the collecting the 24-hour urine sample is problematic. There's a practical challenge with respect to that. And even in the dopamine hypersecretion, your fractionated plasma metanephrine is a test of the choice. So answer was none of the above. Sadly, most of you could not make it correct. And this is a letterboard check. And again, we have almost the same pattern, but nothing. So Dr. Archana, Dr. Aditya, Dr. Priya, Sachin, and all the best. And you still have a lot of time to catch up, because we have done through only less than 50% of today's quiz. And the last question which we discussed, it's directly from the Williams 15th edition. So these are the conditions where you do the plasma metanephrine test, because it has got a higher false positive chances. So we choose it in the cases of whenever we have a high clinical suspicion, and also whenever we are employing a pheochromocytoma evaluation in children or pediatric patient, it becomes a test of a choice, and also in the patient with dopamine secreting tumors. So let's proceed to the next question, and this would be a question number 5. So out of 10, and wish you all the best. And we have a question number 5 on your screens. So need to discontinue certain medication before MIBG scan. But drugs that can cause depletion of the storage vesicles need to stop at what durations? So there are various mechanisms by which the drug can interfere with MIBG uptake, and one of the mechanism is depletion of the storage vesicles. So I'm just talking about this mechanism, depletion of storage vesicles. So these drugs need to be stopped 24 hours before MIBG administration, 48 hours before MIBG administration, or 72 hours. And the correct answer was 72 hours before MIBG administration. And drugs which interfere with your uptake need to be stopped 48 hours before MIBG administration. And only about 50% of you can make this answer correct. So, and this again is coming from this table, which is from your Williams, and it's very important to go through the tables and charts and figures of the Williams, because most of your, the exams are, or even the quiz questions are taken directly from these. And let's go on to question number 6. So here is the question number 6 on your screen. So state true or false. The cluster 1 related paragangliomas are most likely to be associated with a high basic symptom and sustained hypertension compared to cluster 2. So this statement is true or false? So this statement is saying cluster 1 has a high symptoms and sustained hypertension compared to cluster 2. So whether this statement is true or false? So the correct answer was false. Sadly, most of you have answered this wrong. And so basically, this is a very important review from endocrine reviews, which I want you to refer to. It's a personalized management of pheochromocytoma and paraganglioma. It's a beautiful review where it is described about various clusters 1, 2, and 3 of pheochromocytoma, and what are the clinical features, what are the behavioral patterns, what are the chances of transformation into the malignancy and what are the imaging modalities which you would be choosing. And I've taken the table from this review, and you see cluster 1 is associated with the lower basic symptoms and sustained hypertension. On the contrary, cluster 2 is associated with the higher basic symptoms and episodic nature, means more of a shift kind of, fluctuating kind of symptoms in the cluster 2 is there. So the answer for that, the previous question was false. And again, all the students should refer to this beautiful review. You will have a much better understanding of a pheochromocytoma. So this is the next question. So please observe this image. So we have 4 components of this image. So connect all this pictorial information and identify these conditions. So please take your time. I'll wait here for 5 to 6 seconds. So connect all the components of these images, make a differential diagnosis in your mind, and then I would be asking you the questions related to this. So now we have a question related to this image, and the question is very simple. I'm sure all of you would be able to answer this. So refer to that image and identify this condition. So what was that conditions? So, and you have options as well in this question. So options are MEN1, MEN2A, MEN2B, and VHL, von Hippel-Lindau syndrome. So which one is the correct when you connect all the pictorial representations of the previous question? So everyone has voted, and the correct answer for this is, so correct answer, most of you could answer it correctly, and that was a very simple one. So it is MEN2A, and we can see that the first half was showing the neck surgery, possibly the medullary thyroid carcinoma, which has been operated.
So some connectivity problem might be there. So very soon we'll come again. So most of the question have taken from the Williams, and also in examination, examiners are, most examiners are very aged, so they are asking mainly questions from the Williams during examination, PG examination also. But we should be prepared with these newer articles also, particularly JCM, and sometimes many good reviews are coming in NGM also, and this endocrine practice also. So we should see them also. So let's see. Okay.
Sir, extremely sorry, some technical glitch. I got disconnected. I'll just quick check. So I'll start from where we left. So there's nothing we have missed. So quiz, we are continuing. So I'm sharing my screen again. We were at question number 8. So we will. So I hope everything is okay. Everyone is with me. So I'll give some around 10 seconds again. So everyone are ready. So we have all the players ready, sir. So I'm sorry, there was a technical glitch from my end and I got disconnected. So nothing we have missed. So we have done the question number 7. Till question number 7 we completed, and we are about to enter the question number 8 now. So here comes your question number 8 on your screens. So question number 8 is there, and please, we are looking for the fastest answer. So the question number 8 is, all of the following drugs should be avoided during operative period for pheochromocytoma, except. So this was also discussed during the case presentations. We can use all the drugs when which one except. So which one is a safe drug to be used during operative management of pheochromocytoma? So your options are fentanyl, ketamine, atropine, and barbiturates. Again, it's a simpler one, and I'm sure most of you would be able to strike it. Sadly, many of you missed it. The correct answer was barbiturates. Barbiturates are a safe drug to be given during the operative management, during the anesthesia management of pheochromocytoma. Fentanyl, ketamine, and atropine are contraindicated. And again, this question. So let's have a check on leaderboard before we discuss the discussion of the previous question. And at this juncture, so we have only 2 questions left, and we have a close fight. And between Dr. Archana, Dr. Aditya, and Isha, and Dr. Sheikh, Dr. Prag are also little behind, and still you have options. If you can answer the correct answers correctly and at fastest finger, then you can catch up still. So the explanation for previous question was from this, again from Williams edition, 15th edition. So there are certain, there's a certain peculiar management during the perioperative period of anesthesia where fentanyl, ketamine, morphine should be avoided because they cause potentially catecholamine release, and even parasympathetic nervous system blockade with atropine can cause tachycardia. So these drugs should be avoided, whereas barbiturates, etomidate, and propofol are the safe to be used. And it's for all the endocrine students, these components are very, very important because you would be engaged during the perioperative management with the surgery and anesthesia team. So having said that, now we proceed to the question number 9, and this is the second last question of today's quiz. Wish you all the best. And again, I want to tell you that we are looking for fastest. So it's not only correct, so please look at the time as well. And here comes the question number 9 on your screen. So which genetic syndrome is most commonly associated with bilateral pheochromocytoma with predominant norepinephrine secretions? This simpler one, again, was discussed very elaborately during the case presentation. So you have neurofibromatosis 1, MEN1, 2, VHL or SDHB mutations. So everyone is voted, and let's see what is the result. And so yes, so very nicely, most of you could answer it correctly. The answer is von Hippel-Lindau syndrome, and it is associated with bilateral pheochromocytoma, and it secrete predominantly norepinephrine. On the contrary, MEN2 syndrome is associated with the metanephrine secretion. And what is the explanation for that? The PNMT is downregulated in VHL. So the answer was VHL, and let's have so we proceed to the last question of today's quiz. Please take care of the time management, especially for the students who are having a close fight. So here is a question number 10 on your screen. So extra-adrenal paraganglioma often lacks significant elevation of plasma metanephrine compared to the adrenal pheochromocytoma. So why does this happen? What is the reason explanation for this? So paraganglioma lack catecholamine secretion. Paraganglioma do not express COMT, or they lack PNMT, limiting epinephrine production under the cortex influence. Which is the correct answer? So it was again a simpler one, but sadly, few of you missed it. And the answer was they lack the PNMT epinephrine production under the cortex influence. So we know the medulla has a PNMT enzyme, which is called as phenylethanolamine N-methyl transferase, which causes a epinephrine production under the influence of the cortex, and that is a cortisol. So that is why the extraadrenal paraganglioma does not have basically lack the plasma metanephrine compared to and they have a normetanephrine excess. And we have completed with today's quiz, and let's have a check at leaderboard. And we have a cash prize of 10,000 rupees for only a first winner. So let's see who is today's winner. So the scoreboard is settling down, and we have Dr. Archana Rao with 825 points to be a winner of today's quiz. Congratulations, Dr. Archana Rao. You can contact me for your prize money, but please, nothing to worry for the others. You had a very good fight, and thank you. And thanks for the participation, and wish you all the best. Thank you, sir. With this, we come to end of today's case capsule, and shortly we would be, giving you intimation about the April session, April chapter of the case capsule. Thank you.
Thank you. Thank you very much.
Thank you, everyone.
Thank you, sir.